Good to go? All right, good evening. Thanks for everyone who is here in person and those who are tuning in through the live stream. So I'm Dr. Zacharias. I'm an orthopedic sports medicine surgeon here at Freighter South. So I'm excited today to talk to you about kind of some of the really amazing things that we get to provide, some of the new advancements in sports medicine that are out there, and kind of giving, just touching on a background of what these advancements are, how we utilize these to help patients, because some of this stuff is a little bit tricky when you start looking at, what's out there on the internet, on Google, and you start looking at different options for treatment, dealing with different types of syndromes. It comes down to getting into the weeds and figuring out what's the right thing to do and what's not. So we're going to just touch a little bit on that today. So a little bit of background on me. So I'm new to this area, so I've been in practice here at Freighter South for a year and a half. I did my medical school training at the Medical College of Wisconsin. I did my orthopedic surgery residency at University of Kentucky, and then I spent 1 year at University of Wisconsin for my sports medicine fellowship training. So we're going to kind of jump right into it. I do have a couple disclosures, though, none of which are really going to be talked about in this. So I am on the editorial board for the Journal of Arthroscopy. I have received research funding in the past for some of my research, and we're actually going to talk on one of those topics here embedded in this presentation. And I'm also part of the American Shoulder and Elbow Surgery Bone Instability Group. So. Speaking towards the shoulder, there's a lot of amazing advancements that we have coming down the pipeline in the shoulder that we've started to utilize more and more as our understanding of how to treat some of these shoulder pathologies, though common, have changed. So some of these topics like rotator cuff and shoulder dislocations, those seem like really common topics, and that's because they are. So we see these all the time. So those have garnered a lot of research, a lot of attention, and we're getting better grasp on how we should take care of these. So this is a picture of a torn rotator cuff. So what we're looking at, we're kind of looking at from the side of the shoulder. This is the humeral head. There should be tendon attaching here. We should not be able to see the humeral head looking at from the outside of the shoulder, right? We should be able to see a tendon attaching right here. So this is a torn rotator cuff. This is something where this can happen traumatically, or this can kind of happen over time where patients may develop this tear and it gets worse over time. The rotator cuff, once torn, does not have the ability to heal itself. Doesn't matter what we inject in. If we inject stem cells, if we try to do physical therapy, the physical therapy is trying to compensate for the torn rotator cuff. However, it's not going to heal it. So in those who are having continued pain and dysfunction with their shoulder and who have a torn rotator cuff on MRI, this is something where we consider repairing. And this is what we see at the time of surgery. We'll see this rotator cuff completely torn off the bone. So the treatment for this has kind of predicated initially on how do we fix this? Open arthroscopic, all right? Now most of us these days are doing it arthroscopic, all right? So we're able to fix it through the scope, through small little poke holes around the shoulder. All right, now the question is, what do we use to fix this? How are we gonna anchor this in the bone? So we have some really amazing anchors that really give us the ability to get good fixation in the bone and pass sutures through the tendon. Do we do a double row or a single row fixation? Now what that means is, do we just put one row of anchors along the bone here, or do we bring it over to a second? My kind of take on that is do what the shoulder needs, right? Do the right repair for that shoulder. So if we have plenty of tendon, it's not retracted, we'll do the double row. It's a more solid fixation. If you don't have plenty of tendon, do the right thing, do a single row. Augment it if we have to. And that's where a lot of our research has gone into. So we can do a repair, right? The repairs have been around for a while. There's different techniques though. Scott Snyder out in California has kind of popularized this, where we poke tiny little holes in the bone right here to really get some of those bleeding elements from the bone. So that's another thing that we can kind of tweak our rotator cuff tears in order to get some biology to it, right? So we can fix it, but the question is, how do we get it to heal? How do we get it to not re-tear? How do we get this to do well? Because previous research has shown 40–50% of these big rotator cuff tears won't heal. That's a big number, especially when you talk about how tough it is to go through a rotator cuff surgery. We want to make sure we're tipping those scales in our favor. So in these bigger repairs, what we can also do, you get the good repair, so you can see that I can't see that hole anymore. It's repaired down. We have sutures repairing it down. We can put a patch over the top of it. So we have bioinductive patches or implants that we can lay over the top of the rotator cuff repair. So this is the initial tear. This is the repair with the sutures over the top of it. And then this is a patch laid over the top of this repair to help give substance to the tendon, let it heal better, give a scaffold for it to incorporate into, and really give a more robust repair. Right, when this first came out, the first big clinical study, and this was when I was in residency, showed that 24 out of 25 massive rotator cuff tears healed. Right, those are numbers that we never would have experienced before that. So this is something that has really helped us in bringing a better solution for these large rotator cuff tears. All right, so this is something that we are utilizing more and more for our rotator cuff surgeries here at Froedtert South. So let's kind of shift over to the shoulder instability. So shoulder dislocations, it's not like in the movies where someone dislocates their shoulder, they pop it back in, they're good to get back into the fight. That's not how it works. Shoulder dislocations, the initial shoulder dislocation, then reduction, that's the tip of the iceberg. But in order for a shoulder to pop out of socket, something has to happen. All right, most of the time the labrum is going to be torn and you're going to develop some damage to the soft tissue structures that stabilize the shoulder. Now, if someone under the age of 20 dislocates their shoulder, if they're going back to a contact sport, 90% are going to redislocate. That's a high number of repeat dislocations. Now, if they keep redislocating, they can start developing bone loss to the shoulder socket. That gets into a tricky situation. All right, you start losing bone to the shoulder socket. The shoulder socket is already essentially like a golf tee, right? And it's holding that humeral head, which is the golf ball. So if you start getting a shallow golf tee, if anyone's played golf and they have a little chip on their golf tee, that ball just falls right off, right? So the same thing with the shoulder socket. We have to reestablish that shoulder socket and the stability of the shoulder. How can we do that? Well, nowadays, one amazing advancement has been this distal tibia allograft. All right, so allograft, whenever we see this word, that means it's coming from someone who's deceased, someone who's donated their tissue to use for medical procedures. So this study looked at, all right, how do we solve this problem? Someone dislocates their shoulder, they have a bunch of bone loss, we need to reconstruct it. So we figured out if we take distal tibial allograft from someone who's deceased, we can recapitulate that shoulder socket. So this is what the distal tibia looks like. All right, so we make it's nice and contoured just like how the shoulder socket is. So we can take this distal tibia and we can put that on the face of the shoulder socket, and then we can repair the soft tissues over the top of that. The amazing thing is nowadays too, we can do this arthroscopically. So now instead of making an incision in the front of the shoulder, I can do this through a scope, right? That means I don't have to cut through the rotator cuff. I don't have to, hope that the rotator cuff is going to heal. I can really not, mess around with the anatomy and really just reconstruct the anatomy and then also repair the soft tissue structures over the top. All right, so this is something that is kind of, a high-level surgery that we can offer now, and it's amazing. It's been, really allowed for by the work of Dr. Wong in Canada, who was gracious enough to kind of show me how to do this surgery and teach me how to do this. So this is a really cool thing that we can offer here at Froedtert South now. So this kind of gets into some of my research and residency. So when I was a resident, there was, I was at a talk and the lecturers were talking about shoulder dislocations. They were talking about, well, should we be transferring bone in? Should we be tightening up the shoulder capsule in the back? All right, and they were arguing back and forth. So if you're ever at a conference and people are arguing about what's the best solution, the louder their voices get, the more uncertainty that someone usually has. So if someone's arguing about that, that just means that there's no good solution, right? The fact that you have to have an argument means there's no consensus in it, right? So whenever you're having these debates at medical conferences, you should be, keyed into the fact that we don't have a great solution. And that was what shoulder dislocation was. So I remember sitting in the crowd and I'm like, why don't we just reconstruct the labrum, right? We're doing it in the hips. Why can't we do it in the shoulder? What could we do to do that? We could use the biceps. The biceps is right there. So biceps is something that we commonly will tendinitis. If someone dislocates their shoulder, they can get something called a slap tear. So the biceps runs up the front of the arm and attaches up on the top of the labrum, right? That's something that's commonly torn. Our treatment for that is we reattach it down here on the humerus, okay? But we're not using that biceps tendon for anything else. So we could reconstruct the labrum. So this is what it looks like. This is a lab specimen from my research. So what I'm doing here is if you don't have a labrum in the front of the shoulder, we can actually reconstruct one right here. So we can give you that bumper to the Gulf tee to help keep the shoulder stable. So in those who don't have a labrum, so this is some pictures where we don't see any labrum here. This is cartilage right here. So this is the shoulder socket. This is cartilage. There should be a labrum right here. It's missing. It's absent. This is a long-standing shoulder dislocation. So there's nothing for me to repair. If we can't repair, we have to restore the anatomy somehow. So we reconstruct it. In sports medicine, it's all about restoration of anatomy. Sometimes we have to reconstruct it and we have to do tissue grafts. So you can see here, there's some remnant labrum, but you can see it's all frayed. All right, and so there's nothing that's keeping the shoulder stable. There's no labrum. So what you do, or what I did on this one, is you reconstruct it. You put the biceps in here, and you can see we now have a bumper on the shoulder socket. We now have a labrum. All right, so this is a research study that I did in residency, and it's garnered a lot of attention. It's been pretty cool. So I've done podcasts on this. I've talked at several conferences on this, and now other surgeons are starting to publish their techniques on a research project that I did as a resident. So it's pretty cool. So there was actually, this past weekend, there was just a research study that came out where someone published their technique on it. So this is something that offers a solution where we once had a problem without one. So let's kind of shift down the arm a little bit and talk about what are the advancements that we can now offer for the throwers. A lot of baseball here in Southeast Wisconsin. And I'm excited to discuss about the UCL reconstruction. So anyone who follows baseball has probably heard of Tommy John surgery. So Tommy John surgery is when you rupture the ligament to the throwing elbow. So this ligament that attaches the medial epicondyle to the ulna, right? It's responsible for preventing the stress when you throw a baseball. Over time, that can rupture, or it can even happen just like that on a throw. You know, athlete throws the ball, feels a pop, pain, unable to throw again. So for those who are younger, who haven't had as many miles on their elbow, on their UCL, this is now a solution we have to get them back throwing, pitching at around 6 months, where it used to take over a year if we would reconstruct the ligament. So we can now put this brace inside the elbow and repair the ligament. So this brace acts as kind of a check rein. It acts as a backstop to prevent excess stress to re-tear the repaired ligament, all right? So they tried this back 20, 30 years ago to repair these ligaments, and they couldn't, right? We didn't have the technological advancements. We didn't have the materials, the implants in order to do that repair. And I say I wasn't around doing surgeries 20 years ago, but the Orthopedic Society itself. But we now have the technology and the implants and the techniques in order to do this. And there's been some really great work by Dr. Dugas down in Birmingham at the Andrews Institute to pioneer this and really make this a successful surgery. So now we're seeing return to sport rates around 90% at 6 months, where previously we would have to do a big ligament reconstruction, grab a tendon from their palm of their forearm, and then transplant it in here, or take a hamstring tendon and transplant it to the elbow. Now we can do a repair. Pretty awesome. So, this is something now that I've been doing quite a bit of here in this community, and something I was excited to kind of bring to this community more and more, and that's the hip preservation. So, speaking from someone who has had hip preservation surgery, I'm two years out from my own hip scope procedure. So this is something that's a little bit near and dear to my heart, because I've been through this as a patient, and I understand what hip pain can do and how it can affect your life. And so we're going to talk about the hip arthroscopy, and we're going to talk about some of the reorientation procedures that we have to do. So this is a hip X-ray. And this is where you can see that there's a big bony prominence on this hip right here. So it's almost like a square peg in a round socket, right? You can see that how this, if you bring this hip up, it's gonna jam into right here. And what we see in patients when they have that extra bone right here, as they bring their hip up into flexion, they will tear the labrum. So they injure the labrum right here at the hip socket. So this is just kind of showing a cut view of it, where this extra bone will run into the labrum and you'll get tearing right here. And this is actually what it looks like at the time when I fix these. You see the tearing right where the labrum meets the cartilage. So patients who have this issue, they'll have pain with prolonged sitting. Long car rides are going to be bothersome. They're going to have pain when they're running more or doing jumping activities. Those who play like soccer, football, hockey will definitely have symptoms, even while they're doing the sport or really the next day too. All right, so this can be something that really can be disabling and really bothersome. Even if you talk about, just trying to have a desk job, it can be painful just sitting all day. So why does this happen though? Is this something that develops or was it an injury, right? Our best hypothesis of why this prominence occurs or why this flattening occurs is that it occurs during the adolescent growth spurt. So a protective mechanism of where the growth plate is. So this faint line right here is actually where the growth plate once was. So our bones grow at the ends of the bones. We have growth plates. So if someone is involved in high-level sports, if they're just really active, doing a lot of sport training, the growth plate, we think, widens out there to prevent a growth plate fracture. So it's a protective mechanism, albeit one that can cause damage down the road, but that's not the way our bodies work. Our bodies are not thinking about the future, they're thinking about the here and now, right? Protecting this from developing a growth plate fracture here and now. So is it advisable to, between the ages of 12 and 14, avoid high-level sports training? Right now, we don't advise against that, right? Because not everyone's going to develop it. It's just a higher rate of it. It's not 100% though. So if we take, a soccer study from, a world-class soccer team in the Netherlands, right? So they followed their kids between the ages of 12 and 16. They found that everyone below the age of 12, they didn't have any of this, right? They developed it as they grew, where about 30–40% did end up getting it. And unfortunately, about 20% did end up starting to develop hip pain by the end of the study. But it's something where not everyone's going to get it. Just because you're doing high-level soccer at that age doesn't mean you're going to get it. So here on the MRI, we see, here's the hip socket right here, here's the labrum, and we can see a tear right there. All right, so, did I pass? No. So how do I fix this, right? At the time of surgery, I'll get all these different x-rays, and this will kind of show me the layout of the bone impingement, right? So we've tried physical therapy, we've tried, maybe injections, we've tried anti-inflammatories, none of that works. All right, it's time for the surgical treatment. How do we actually do this procedure? And this is kind of where technology has really helped me on this procedure. So this is kind of some artificial intelligence where this is prior to doing the surgery, and then this is after doing the surgery. So this artificial intelligence maps out the hip for me, it maps out the area of impingement, and it tells me, all right, what's the recontouring I need to do in order to prevent this damage from happening again? So I get all these different views, and you can see prior to surgery, right there, this is all the extra bone that has to be recontoured. And I'm going to show you kind of what that looks like. You can see all this extra bone that's causing an impingement in the hip. So that way, hopefully we can take a hip that starts out like this and get it to one that looks like this. So this is a video of what a hip scope looks like. So this is a tough surgery. This is where we're using a 70-degree scope. You can see this is the labrum here. This is the femoral head. You see all that labral tearing right there. So that's right where the labrum meets the hip socket cartilage. And that's all tearing of that labrum off of the hip socket. So when you start seeing hips like that, you can really see how having that extra bone there can really cause a lot of damage to the hip joint, right? This is a 30-year-old patient, that's their hip right there. And you can see all that damage in there, right? That's not a hip we want to see in a 30-year-old. We want to be able to correct that so they don't develop arthritis in the future. All right, so I put these anchors around the edge of the hip socket, And you can see those anchors and really stabilize the hip, and then kind of clean up some of this frayed labrum. So you can see the before and then the after. You can see how that labrum's attached nicely. There is irreversible cartilage damage. So what I tell my physical therapists is that if you have someone who's not getting better in 6 to 8 weeks, we need to know about that, because there's plenty of studies that show if we let this go on past 6 months, 1 year of symptoms, and they're trying to tough it out, that's developing damage that's irreversible that I can't change at the time of the procedure. So, and plenty of studies show that patients don't have the same outcomes if we wait longer to do the definitive treatment. So this is kind of what it looks like, but then we have to take care of what caused it in the first place. So you can see that the labrum's getting a nice good suction seal on the femoral head, and then we're going to end up doing the burring procedure next to kind of take care of what caused this in the first place. And this is all the extra bone on the head of the femur. You see that big bump there on the neck of the femur. Those are the blood vessels. So I always get this view during the scope to avoid the blood vessels, because we don't want to make things any worse for the patient. So we're going to burr down this excess bone to allow the hip to move in the hip socket without getting stuck and causing the injury that we just had to fix. So, and then at the end of this procedure, we're going to close up all the capsules. So this is just kind of showing the burring down. We get final burring. And then at the end of the procedure, you can see these sutures to close up the capsule. We know now more than ever that closing up the capsule at the end of the surgery is an important thing. I tell all my patients, I was like, if you don't get along with me, if you are looking for a hip scope and you want to get a second opinion, it doesn't matter, so much if I do it or not, but please just go to someone who's going to close your capsule. I want that to be a question that you ask, because we know more and more that closing this capsule is an important part of the surgery. Now, why wouldn't someone close the capsule? Well, it's tough, right? It's a tough part of the procedure. It's honestly one of the tougher parts of the procedure. It doesn't bill. We don't get paid for it. It's extra time in the OR that you're not billing for, but it's the right thing to do, and patients benefit from it, right? So it's something that we should be doing. So that is a word of advice I give my patients for that. And then on the other side of things, so that was just about the hip impingement. You can have a shallow hip socket where you don't have enough hip socket, right? So that's hip dysplasia. We hear about hip dysplasia a lot with kids. You may know, a relative maybe has a kid who has had hip dysplasia, who was in harnesses when they were a child, or maybe had to have a surgery as a child. I'm going to talk more about the hip dysplasia that I see that presents in adulthood, more so, where maybe they weren't treated as a child, or maybe they still have some residual hip dysplasia after being treated. So what we see is when you have shallow hip sockets, so what we're seeing on here, this femoral head is uncovered. So all the weight of the femoral head is being put on a small surface area of hip socket. Whereas you can see the hip socket on this side kind of curves over the femoral head. So you got a much larger surface area for the femoral head to transfer the weight of the body, all right? So what happens when you have this shallow this shallow hip socket, all the weight is being put on the edge of where that labrum is. I just showed you that video. On the edge, there's the labrum, there's the cartilage. So you're gonna wear out that cartilage, you're gonna wear out that labrum much faster because this tiny bit of cartilage, this tiny bit of labrum is having to accept all the weight. So what we can do for this type of pathology, and I do this surgery with my partner, Dr. Ben Zev, is we make cuts around the pelvis. We do a small little bikini incision up here, and through that little window, we can make all these cuts around the pelvis, around the pubic symphysis, and then around the back and the ischium, and we can reorient the entire hip socket. So the hip socket is completely broken free from the body, and we can put it exactly where we need to, all right? And this is something where we talk about advancements in surgery. Where are we going in surgery for some of these procedures is we are modeling our procedures ahead of time. We are getting 3D CT scans so that way we can know exactly where we are putting this hip socket. We have models and templates made in advance that we use in surgery to make sure that alignment's perfect. Dr. Ben Zev and I have another x-ray machine attachment that we use for hip replacements, but there was actually a award-winning research study that just came out recently out of Utah where they used it for their periacetabular osteotomy. So we are doing that too here. So we're one of the few centers who is actually using this technology in order to make sure that these hip sockets are aligned as perfectly as we can, so we can make measurements real time in the operating room and not sit there after surgery and be like, oh shoot, I wish I did it differently, right? We can make the measurements right then and there. All right, so let's kind of drop down a little bit further in the lower extremity to the knee. So the knee, these are a lot of the surgeries that I do here. So these are all different ligaments that we reconstruct around the knee. So the anterior cruciate ligament, that's something that we hear a lot of. But there's also the posterior cruciate ligament, the lateral side, the medial side. So there's all those different ligament reconstructions. Sometimes we have to do all these at the same time. That's a bigger procedure. There's cartilage transplant procedures, meniscal transplants, meniscal repairs, and then stabilizing of the kneecap. So let's talk a little bit about the ligament and reconstruction and where we're at with that. So back in the day, they would drive one single wire through the tibia and then through the femur. You can see that this is going kind of straight up. That's not the way that the ACL was made. The ACL is made in more of a angled direction, but that was kind of the best technique that they had, the best advancements in their technology. Nowadays we do more of this accessory medial portal, or even like different types of techniques, kind of drilling from the outside of the knee as well, with different types of guides that we have available. And what we have seen is that drilling these special ways, like drilling, for example, in this study, drilling through a portal right here gets you where you need to go 97.7% of the time, whereas the old way, 61% of the time. That's not good odds if we're putting the tunnels in the wrong spot that much. And the number one reason for an ACL to not do well, it's that the surgeon messed it up, plain and simple. So that's kind of something to really kind of humble yourself on, is that the number one reason that the patient's not going to do well after the surgery is that I messed it up. So that's where we got to be really, really precise on our tunnels. So, something that I will do here is I'll drill through the femoral tunnel, and every time before I buy the tunnel, I get this picture right here. I want to make sure that this tunnel is about 1 millimeter from the edge. So I'm drilling this tunnel with a 1 millimeter margin of error, so really not much error. And you really, if you're going to do an ACL, you got to be prepared to live on the edge a little bit, because you're really dealing with not much room for error. So, but if you don't put it here, the patient's not going to do as well. All right, they're just not. So we got to get these tunnels in the right spot. On the tibia, same thing. I get x-rays on all my tibial tunnels because those have to be in the right spot. Otherwise, the patient's either going to impinge when they try to straighten their knee out, or they're going to have to stretch out their graft in order to get their knee flexed. So, but here's a new advancement that has really picked up a lot of steam lately, and that's the lateral extra-articular tenodesis. So what happens in an ACL, when you shift your tibia and when your knee kind of goes through that rotation, that's enough rotation to tear the ACL, what happens is you actually can injure the capsule on the side of the knee. So in order to kind of, for those who are higher risk for repeat ACL tears, so younger patient, maybe they are a little bit more ligamentously lax, so that they can double jointed perhaps. They're going back to a sport like football or soccer where they're going to be cutting more. They may be a younger athlete who has some anatomic risk factors. We can now reconstruct that capsule on the side. So we take a slip of the IT band and we can plug that into the side of the femur and really give extra kind of balance to avoid excess interrotation. And this has really dropped down repeat ACL tears quite a bit. So this is where anytime someone's coming in for a second ACL tear, or anytime someone's got one of those risk factors, we're talking about this procedure in order to really drive down that re-tear rate. So typically we think of ACL re-tear rate around 5%. However, I did do a research study at University of Kentucky looking at those who are skeletally immature. In that study, we found that a female athlete with open growth plates, 30% chance of repeat ACL tear in either that knee or their other knee, right? So 30% of the time. So if I'm looking at a parent of a skeletally immature female athlete, I need to be ready to tell them, hey, there's a 30% chance that we're going to be doing this again, right? That's a big time risk factor. So that's where there's a couple things we can do. One, for that knee, make sure we're doing the right surgery, getting the tunnels in the right spot, adding this type of augmentation to it. When they go back to sport, making sure that they're with a good physical therapist. We have to have sports-minded physical therapists that can not only focus on the ACL, but also focus on the other side. In this community, we do need to do a better job of ACL prevention programs. So we do have a deficit for sure, but that's everywhere. So, kind of working towards that as a goal to get more ACL prevention programs out there. So then let's talk about the cartilage stuff. This is pretty exciting to think about how we can transplant cartilage. So if someone damages their cartilage, it doesn't regrow back. Cartilage doesn't heal itself. So we have to actually transplant that if we want to treat it. So this is a patient where they have a big cartilage spot here on their medial femoral condyle. So on the inside part of their knee, this cartilage is all damaged, right? I can't treat that. I can't do a scope for that and clean up damaged cartilage. Whenever we talk about that, the issue with damaged cartilage is it's an absence of something. It's an absence of the smooth cartilage. I tell my patients, having arthritis or cartilage damage, it's not something, it's the absence of something. Just like darkness is the absence of light, smooth cartilage or damaged cartilage is the absence of having nice cartilage. I can't clean that up. I can't make that better without giving you something, and that's new cartilage. So there's no injections, there's no stem cell injections that we have still in 2024 that's going to rejuvenate this knee, right? There's no stem cell injections that's ever been shown to regrow cartilage. In fact, the injections that are commonly called stem cell injections actually don't have the ability to regrow cartilage. You'd have to grow those cells out in the lab, and there is no FDA approval to do any of that at this point for an injection-based product. So our best procedure now for a lesion like this is to take these cartilage plugs from someone who's deceased. So these are fresh cartilage plugs. So they have to go through a donor match process where the donor gets size matched to the patient. There is a kind of a 28-day window that we have where these cartilage cells are still viable. So the donor programs have gotten to be really good. It used to be that you're almost like a transplant surgeon. You're on call when you get a match. You have to be ready to go because those cells have to be good. Now we have a lot more ability to get grafts, so we can actually schedule the surgeries. We don't have to be like on an on-call type basis. So this is what we do here is we can put these plugs in and kind of restore the cartilage there. In addition to just restoring the cartilage, so you see here, big spot of cartilage loss, right? However, also no meniscus. This patient has no meniscus, they're missing a big spot of cartilage. We can transplant meniscus too. So in addition to transplanting cartilage, you can see transplanted almost the whole femoral condyle here, cartilage. We can also transplant a meniscus at the same time. So this is a complete meniscal transplant as well. So we can give them the shock absorber to the knee that caused the cartilage damage in the first place. So a lot of times in sports medicine, we're not only treating the pathology, but we got to understand why this pathology occurred, and we got to be able to treat the underlying cause of why it occurred in the first place, right? This cartilage damage wasn't the issue. It was the meniscal damage that led to the cartilage damage. So we treat the cartilage damage, but we also have to treat the cause. So those are kind of the new surgical stuff that I wanted to kind of touch base on. There's a lot more, obviously, that we do in sports medicine, a lot of other procedures, a lot of different advancements. I want to kind of change gears a little bit and talk about something that we don't talk about maybe enough, and that's kind of the mental health side of what we do, the mental health side of sports medicine, because it is something that we see a lot. With these musculoskeletal issues, it can take a lot from patients, from our athletes. You lose your identity, you lose the things that you love. Say an athlete in high school, they tear their ACL, they can't play soccer, right? They saw themselves as I am so-and-so, a soccer player at this high school, right? They've just lost that now. Now what do I do, right? So this is a study that that I did at University of Wisconsin, where we wanted to look at how our hip arthroscopy patients were doing. And kind of the reason for this is that when you look at major depressive episodes, in those 18 to 25, 17% will have a major depressive episode in any given year. Over the age of 25, 7.1%. In the hip arthroscopy population, 45% of patients prior to their surgery will present some sort of either anxiety or major depression. So what orthopedic surgeons would write on a lot was that in those with mental health disorders going into a hip arthroscopy, they had worse preoperative patient-reported outcomes, right? So on their scoring sheets going into surgery, how do you feel about your hip? How much activity do you have? How motivated? They were scoring considerably worse than those who did not have a mental health issue. However, they also found that after surgery, they weren't doing as well. So our whole goal was to see, all right, sure, maybe their hip's not feeling as well. How are they doing after the surgery when we address the pain? How is the depression doing though? No one's ever looked at it from that standpoint, right? Everyone's looking to see, does the depression affect the hip outcome? We wanted to kind of take a spin on it and see, did the hip outcome affect the depression? So what we looked at is we looked at all our hip scope patients, and we looked at their patient-reported outcomes for the 1 year after surgery. We found that in the 92 patients, 21 of them had clinical depression based on these scores. At the end of 1 year, 76% of those patients no longer reported any depressive symptoms, right? So 76% of patients were no longer even reporting depression. And then also we saw that in this group, those who reported pre-op clinical depression had no difference in how their hip felt after surgery. So we found that just because you have depression or a mental health issue, you should not be excluded from a surgery, right? Especially a surgery like this where it affects your activity, it affects what you can do, and it can really affect your mental health. And we found that the mental health does improve when we appropriately address the musculoskeletal pathology. So here's some pictures from my time at University of Wisconsin. This is me and Dr. Bear. So we were, at one of the football games. This is at Illinois. This is after the Badgers beat Iowa here. These are some pictures of my kids. So that's Ava. She's now 5. Emma is now 3, and then Caden. He's 18 months. So kind of where I come from. Kind of some of the pictures in my journey here. So.